Educational content by Dr. Muhammad Al-Naji Muhammad. Welcome everyone. In this clinical explainer, we are going to break down hypoglycemia, a really common and, potentially life-threatening condition. We're going to cover its causes, how it presents clinically, and of course, the crucial management steps. We'll be focusing on that high-yield information you need for clinical practice and for those specialty exams. Okay, let's dive right in.
So, here's how we've laid everything out. We've got 5 key sections. We'll kick things off with the underlying causes and the pathophysiology. Then we'll jump into recognizing the clinical features and those all-important glucose thresholds. After that, we'll get into the diagnostic workup, and finally, we'll wrap up by detailing management protocols for both out in the community and in the hospital.
All right, first up, the causes and pathophysiology. Getting a really solid grasp of the why behind hypoglycemia is absolutely fundamental. It's what allows you to make an accurate diagnosis and, of course, choose the right management path for your patient. Okay, as you can see, the causes are pretty diverse. You've got things like endogenous insulin overproduction from an insulinoma or something called nocidioblastosis, which is basically an overgrowth of those pancreatic beta cells. Then, of course, you have external or exogenous sources, like a patient self-administering insulin. Organ failure, particularly liver failure, is a big one because it messes with gluconeogenesis. And then there's alcohol. Now, the mechanism for alcohol is a key exam point, so listen up. Alcohol is thought to sort of redistribute blood flow in the pancreas, shunting it toward the endocrine parts, and that can cause a really exaggerated insulin secretion.
So when blood sugar starts to drop, how does the body fight back? Well, it's this beautifully orchestrated hormonal cascade. The very first thing that happens, even before those counter-regulatory hormones kick in, is the body slams the brakes on insulin secretion. That's immediately followed by a surge in glucagon. It's only later in the game that growth hormone and cortisol show up to help out. Understanding this sequence is just so crucial for interpreting dynamic function tests.
Now let's see how all that science actually translates into what you'll see in a patient. And here's something that's vital to remember. The severity of a patient's symptoms doesn't always line up perfectly with their blood glucose reading. This is especially true for patients with long-standing diabetes who can sometimes develop what we call hypoglycemia unawareness.
The symptoms are usually split into 2 main groups, and it's all based on the underlying physiology. On the left, you've got the autonomic symptoms. Think of these as the body's early warning system, like the alarm bells going off. They're driven by that release of adrenaline and glucagon. The symptoms on the right, the neuroglycopenic ones, are a lot more sinister. This is what happens when the brain itself is literally being starved of glucose.
So, this number is the first critical point you need to remember, 3.3 millimoles per liter. This is the threshold where that sympathoadrenal response gets triggered, leading to those classic symptoms we just talked about, the sweating, the shaking, and that feeling of anxiety.
And then we get to the next, even more dangerous threshold. Once you drop below 2.8 millimoles per liter, the glucose supply to the brain just becomes inadequate. And that's when we start to see that neurological dysfunction, the confusion, the weakness, the changes in vision. This is a true medical emergency.
And if that profound hypoglycemia goes uncorrected, the neuroglycopenia can progress to its most severe forms. We're talking about convulsions and ultimately coma, which can unfortunately lead to permanent brain injury or even death.
Okay, so what happens when the cause isn't immediately obvious from the clinical picture? Well, that brings us to the diagnostic investigation. When a patient shows up with unexplained hypoglycemia, our job is basically to play detective. And our 2 primary clues are the serum insulin and C-peptide levels. Now, before we try to interpret any results, we have to be crystal clear on what C-peptide is and why it's so useful. You see, when the pancreas makes proinsulin, it gets split into 2 parts, insulin and C-peptide, and they're released in a perfect 1-to-1 ratio. What this means is that C-peptide is an excellent, really reliable marker of exactly how much insulin the patient's own body is making.
All right, this table right here, this is extremely high yield for exams. So let's walk through it together. Scenario 1, you get back labs that show high insulin and high C-peptide. Well, since the C-peptide is high, we know the insulin has to be endogenous, coming from inside the body. This immediately points you towards an insulinoma or maybe sulfonylurea use. Okay, scenario 2, high insulin, but this time a low C-peptide. This tells you the body isn't making all that insulin, so where's it coming from? It has to be an external source, an exogenous insulin injection. This is the classic picture you'd see in a fictitious disorder or an accidental overdose. And finally, scenario 3, low insulin and low C-peptide. This pattern tells you that the hypoglycemia is not being driven by insulin at all. This should make you think about other causes, like alcohol, sepsis, or adrenal insufficiency. So, once we have a handle on the diagnosis, let's pivot to management. We'll start with the community setting. This is the protocol that's most relevant for patients with diabetes who are managing their condition at home.
The approach here, based on BNF guidelines, is really a stepwise process. First things first, if the patient is conscious and can swallow safely, you give them 10 to 20 grams of a fast-acting oral glucose. This could be in a liquid, a tablet, or a gel form. Now, for more severe episodes where the patient can't take anything by mouth, a family member or a caregiver can administer an intramuscular or subcutaneous glucagon injection from something called a hypo kit.
All right, now let's bring the patient into the hospital. The principles are pretty similar, but our options are a bit more expanded, especially when we're dealing with a severely unwell patient. So again, the decision pathway all comes down to the patient's status. If they're alert, we do the same thing. Use quick-acting carbs. But if they're unconscious or can't swallow, we've got two main options. We can give glucagon, just like in the community. Or if we have IV access, we can give an IV glucose solution directly into the bloodstream. This gives you a much more rapid and reliable response. And you'll typically give this through a large vein to avoid any issues with extravasation.
So, to wrap everything up and to test our understanding, let's think about this question. Fictitious hypoglycemia presents with high insulin and low C-peptide. Why is that? Think back to our diagnostic table. The answer, of course, is that the commercially available insulin that people inject doesn't contain any C-peptide. So an injection is going to raise serum insulin levels for sure. But the body's own pancreas, sensing all that insulin and the low glucose, shuts down its own production. And the result? A suppressed C-peptide level. Nailing that distinction is the absolute key to making the diagnosis.